This is Jennifer Gibson with Axxess, and today we're going to be talking about the Z codes and status codes, which is part 11 of our Navigating the Highway of ICD-10-CM series. We're glad you're with us today, and thank you for trusting us for your educational needs. Let's go ahead and get started. Our objectives today are to understand why proper coding is important, to learn who is responsible for applying and assigning diagnoses, and to study guidance for the use of Z codes in ICD-10-CM, and then apply that knowledge to common home health scenarios. As we do in each part of our series, we briefly go over the OASIS C1 guidance manual here regarding who selects the diagnoses and the coding. But again, as we always say, be sure that you go back to part 1 of the 12-part series if you have more questions about this topic, as it's more fully covered in that section. Now, according to the OASIS C1 guidance manual, the selection of the primary and secondary diagnosis must be made by the assessing clinician. That assessing clinician is expected to be the person who understands that patient's overall medical condition and care needs before the selection of the diagnoses are made. In other words, that clinician is the person who puts two and two together, including the information that's received from the referring party, as well as the assessment by the clinician, and then they are the person who sequences the acuity of those disease processes according to the guidance. So again, diagnoses are based on assessment findings, the medical record, and the input from the physician. According to the OASIS C1 guidance manual, the assessing clinician should be the person who records the primary and secondary diagnosis in M1021 and 1023 on the OASIS. That doesn't mean that they have to put the actual ICD-10-CM code, but they should be putting the code title or what parts of the code title they know to help the coder understand what disease process is the most primary acuity or the primary reason for home care, and then sequence the others according to acuity. Once that is done, the coder can then add the code after that assessing clinician has determined the primary and secondary diagnoses. The criteria for the primary diagnosis should be that diagnosis that's most related to the current plan of care, and if more than one diagnosis is being treated, as it usually is in home health, right? The diagnosis that represents the most acute condition or requires the most services should be assigned in the primary diagnosis position. In other words, this diagnosis is the chief reason for home health, it requires the most intensive skilled services, and it's not a Z code unless absolutely necessary. When selecting secondary diagnosis or diagnoses, consider the following criteria. The codes that are in the secondary positions are diagnoses that did not meet criteria for primary diagnosis. They're the diagnoses that are also addressed in the plan of care, and they may affect that patient's responsiveness to treatment and rehabilitation. You may have multiple secondary diagnoses, and if that's the case, you're going to list those in the order that best reflects the seriousness of the patient's condition and to justify the disciplines and the services you're going to provide for that patient. As always, we're going to go over a few coding basics before we get into the topic for today. The one thing I like to remind all my coders is to always start in the alphabetic index first when you're in your code book. Regardless of how long you've been coding, when you get ready to look up a diagnosis, you should always start in the alphabetic index portion of your code book. There's information there that will help lead you to the correct code. For example, when you're looking up an entry, a dash at the end of that entry means that there are additional characters needed to complete that code. You should also make sure you check for the guidance C or C also, and if you find that, make sure you treat that as a command and not a suggestion, because oftentimes there's additional information at the entry that's referenced by C or C also that will get you to a more specific code than what you originally looked up. Once you find the code in the alphabetic index, you want to double check that code in your tabular index, and that's the chapter section of your code book. Once you're in the tabular index, you need to check for additional guidance at the chapter level, the chapter block level, the 3-character category level, and then final code level. And these specific pieces of guidance in the tabular are called conventions. So let's get right into our Chapter 21 using Z codes and status codes, which is the last part of your code book. And the title of that chapter is Factors Influencing Health Status and Contact with Health Services. Not every code in this chapter is used commonly by home health. So we're going to start talking about the Z codes and status codes that are commonly used and how we apply those. These codes are used when there's no appropriate diagnosis code in the A00 to Y89 code categories. For example, if you have a patient who donated an organ, or they had a prophylactic mastectomy, or they're having routine aftercare after surgery, or maybe even a personal history of a neoplasm, those are the types of codes that come from Chapter 21 here. Now, Z codes can be used in any care setting. Some of the status codes have to be used as a primary diagnosis only. The Z codes will help indicate a reason for the encounter, and they help to clarify or paint the picture in home health coding. The Z code categories are broken down as you see here. You have contact and exposure codes. We don't use those very often. Inoculations and vaccinations. Again, we don't use those a lot. Status codes, history of codes, the screening, observation, aftercare, follow-up, donors, counseling, and this is not like your social work counseling that you do in home health, perhaps. Encounters for OB and reproductive services. These are things like fertility treatments. We certainly don't do that much in home care. Newborns and infants. Routine and administrative exams, miscellaneous, prophylactic organ removal, and then some non-specific Z codes at the end. Contact exposure codes, those are found in category Z20, and these are used for patients who are suspected to have been exposed to a disease, but they show no signs or symptoms of the disease. These codes show a potential risk. These are not often used, and one instance that I can think of here in Dallas that we would have used these codes had we had the patient on our services, of course, was back when we had the Ebola virus out here. The nurses who cared for the patient who subsequently passed away from the Ebola disease, they had a period of time where they had been exposed, but they didn't all come down with the disease, but there certainly was a big risk of that. So in that case, we would have coded those patients who had been exposed, those nurses and caregivers, with a code from category Z20 to show that they had an exposure to that disease, but they didn't yet have signs or symptoms. And thankfully, they didn't all have signs and symptoms later. Status codes are those codes that indicate a patient is either a carrier of a disease or has the sequelae or residual of a past disease or condition. For example, the presence of a prosthetic or mechanical device from past treatment. Maybe they had a heart valve replacement and now they have a mechanical heart valve. Perhaps they have a cardiac pacemaker or some other medical device, and the past treatment and follow-up from that's already resolved, but we need to show that they have this particular device implanted. These codes are informative because the status might actually affect the course of treatment or outcome. And quite often, for example, if you have a patient who has a mechanical heart valve, they need blood thinners, and those blood thinners require long-term anticoagulation, which can certainly affect the care that you provide. A status code is different than a history code in that a history code means the patient had a problem and they no longer have that condition. So don't use status codes with the diagnosis from the body chapters when the diagnosis code includes information provided by the status code. So here's an example of that principle. In Z94.1, you have a heart transplant status code. If you were also coding T86.2, complications of a heart transplant, you wouldn't add Z94.1 because you already have a code that tells you the patient had complications of a heart transplant. You don't need an additional code that says heart transplant. That's already part of the T86.2 code. So again, the status code doesn't provide additional information, so it should not be used in this example. Some common home health Z code categories are Z16, resistance to antimicrobial drugs. And again, you see guidance there that tells you to sequence the infection first. Z17 is your estrogen receptor status. Z21 is asymptomatic HIV infection status. Z66 is DNR status. Z68 is your body mass index or BMI codes. Z74.01 is bed confinement status. Z76.82 is awaiting organ transplant status. Those might be used, for example, on your LVAD patients who are having mechanical assistance and they're getting ready to have a heart transplant. Z79 is your long-term drug therapies. Z89 is acquired absence of limb. That's with our amputees, of course. Z90 is acquired absence of organ. Z93 is artificial opening status. Z94, transplanted organ and tissue status. Z95 is the presence of cardiac and vascular implants and grafts. And then Z99 is your dependence on enabling machines, such as oxygen. Let's talk next about the difference between family history codes and personal history codes. When you're looking up history codes in your alphabetic index, the first thing you need to realize is that there is a differentiation in the alphabetic index. The first section is the family history, and the second section is the personal history. And if you're not careful, when you start looking at the different diseases that are underneath each section, you're going to be looking for a personal history code, and you'll be in the family history section instead. A family history, for example, means the family member has had a particular disease, and that causes the patient to be at risk, although the patient doesn't yet have this disease, and hopefully they won't have it, right? For example, the aunt and the mother had breast cancer, but the patient does not have breast cancer, but they're certainly at risk for it, then you would want to code a history of in that case, especially if they've had some other type of cancer, for example. The next part that we are talking about is aftercare. Aftercare is when the initial treatment of a disease has been performed, but the patient requires continued care during the healing or recovery phase. It can also mean there's a long-term consequence of the disease. You wouldn't use an aftercare code if treatment is directed at a current acute disease. Now, this gets kind of confusing, especially when you're thinking about patients who have had surgery. You may or may not really know if you should code an aftercare code or if you should code a complication code. So let's talk about that for just a moment. Aftercare means the patient had surgery, there are no complications of the surgery, everything's going as it should, but the patient still needs some kind of supportive care during that healing or recovery phase. For example, if your patient went in and had their gallbladder removed, they had cholelithiasis, and they had a cholecystectomy, and there were no complications, and that patient's discharged home on home health services, in that case, you would code aftercare for surgery on the GI system. If that same patient, however, ended up with a post-op infection, that's no longer aftercare, it's now a complication of surgery, and we would code the complication and the infection. So I hope that helps clarify the difference between aftercare and complications. There are a couple of exceptions to the rule as far as coding aftercare, and that is that you should code Z51.0 Encounter for Antineoplastic Radiation or Z51.1 Encounter for Antineoplastic Chemotherapy and Immunotherapy if you are indeed providing these services in the home. These two codes are always listed first, followed by the diagnosis code. So if the patient is getting chemotherapy at home for cancer, you would always list Z51.1 before the neoplasm or cancer code. Aftercare codes are not to be used for aftercare of injuries. Remember, with our injuries, those come out of the ST chapter, and what you'll see in those codes is that you'll have a seventh character that denotes this is aftercare. You wouldn't use a Z code or status code in that case. Aftercare codes are to be used with other aftercare or diagnoses codes to provide detail. For example, Z48.812 is a status code or aftercare code for Encounter for Surgical Aftercare following surgery on the circulatory system. Then you would also add Z95.1, which is the presence of an aortocoronary bypass graft. That shows just that the patient still has a graft in their system from the surgery, and it gives you more detail. However, don't use a status code with an aftercare code when the aftercare code itself indicates the type of status. For example, if you use the Z code Z43.0 Encounter for Attention to Tracheostomy, you have everything you need to know in that one Z code. You don't need to add Z93.0 tracheostomy status. In other words, the Z93 code doesn't give any more information than you had with the first Z43.0, and that's redundant, so you wouldn't use both codes in this case. There are codes in the Z code section under miscellaneous Z codes that have to do with prophylactic organ removal. And an example of that would be the prophylactic removal of breast due to genetic susceptibility to cancer. So if you have a patient who tested perhaps and realized that she's genetically susceptible of getting breast cancer because her mother and her aunt might have had breast cancer as well, and she goes ahead and decides to have that surgery and remove her breast, you could use a Z code to show that that was a prophylactic removal. Now, if the patient has a malignancy of one site and is having the prophylactic removal of another site to prevent a new malignancy, you would add a code for the malignancy in addition to that Z40 code. In other words, don't use the Z40.0 category code if the patient is having surgery because of a malignancy, like the removal of the testes for the treatment of prostate cancer. That's related and it's not prophylactic, so you wouldn't use the Z40 code in this case. There are 2 Z codes here that can only be listed in primary diagnosis positions. It's not a complete list here, but most of these are not applicable in home health anyway, so I've only added 2 here, and those are the ones that we mentioned a couple slides back. That's the Z51.0 Encounter for Anti-Neoplastic Radiation Therapy and Z51.1 Encounter for Anti-Neoplastic Chemo and Immunotherapy. So again, those are 2 that are most commonly used in home health that will always be in the primary diagnosis position. If you try to put these 2 codes lower down in your coding, you're going to have a claim that rejects, and you may not understand why. Another thing that's pretty common in home health care is the use of status and attention codes. Status means the patient has, but no intervention is needed by the agency staff. We sometimes get a little confused about which of these we should use, and an example is if the patient has a colostomy or a tracheostomy. Now, if you have a patient who has a tracheostomy, for example, but no intervention is needed by your agency staff, you're going to code a status tracheostomy in that case. Whereas an attention code means the patient has the tracheostomy and intervention is needed by the agency staff. So maybe you're doing trach care in this case, and in the other case, status, the patient already knows how to do his own trach care and is doing that daily. Please know that according to CMS guidelines, an attention code status would not be used if all you're doing is providing supplies to the patient, but rather it relates to skilled care actually being provided by the agency. And so some people will consider treatment as delivering supplies. CMS doesn't see it that way. So make sure you only code attention if you're doing hands-on care for whatever the patient has. And then we're going to talk about fall history versus fall risk. Both of these are coded to Z91.81 History of Falls, and this is a Z code that we use all the time in home health. It translates directly to the ICD-9 code, which was V15.11, and the guidance in that section told us to use that code for both the history of and the risk of falls, and that same guidance translated into ICD-10 with the use of Z91.81. Now, if the patient has repeated falls and the provider is investigating the cause of the fall, then you should also use R29.6, repeated falls, and it is proper to code both in some instances. Remember, if the reason for the falls is known, it is inappropriate to code R29.6. Although I will say this is something on this last point that I will probably write the coding clinic and clarify a little bit, because I noticed when reviewing the second quarter AHA coding clinic definitions, they actually used an R29.6 code for a patient who had Parkinson's disease. And to me, the guidance, as you see here on the slide, says if the provider is investigating the cause of the fall and the reason for the fall is unknown, you use R29.6. But the coding clinic, for whatever reason, did go ahead and code R29.6 in a patient who had Parkinson's. So I will be looking for some clarification. And of course, in the future, we'll be doing quarterly updates. So if I find out clarification on that, I will make sure that we include that in our quarterly updates for you. Another thing that's common in home health care is the routine aftercare versus complication. And we went over this briefly a couple slides back. But remember, aftercare is for post-surgical routine care. It's the supportive phase of healing, whereas a complication means there's a problem like an infection or a dehiscence. It is acceptable to code attention to dressing changes or sutures and staples with aftercare, but a code for dressing changes should not be used with complication codes, and that's what I really want to point out on this slide. However, you can code and should code attention to dressing changes or attention to sutures and staples if you have an aftercare code. So like we talked about earlier, if that patient came home after they had their gallbladder removed and you were to remove staples and you're doing dry dressing changes, in that case you would use the status code for attention to dressing changes and or attention to staple removal. However, if they ended up with a post-op infection, you would not code the dressing changes. Let's talk next about the difference between a history of neoplasm and actually coding the neoplasm. A personal history of neoplasm is used when the patient had a neoplasm that has been documented as excised or eradicated, and no further treatment is being directed to that neoplasm. And it is possible to have a history of neoplasm with a current secondary neoplasm still being active. An example of that would be the patient who might have had breast cancer, went ahead and had a mastectomy. They eradicated and removed all of the neoplasm from the breast, and then later on that patient finds out that she now has a secondary metastasis to her kidney, for example. So in that case, you might have a personal history of breast cancer with a secondary malignancy of the kidney. One of the most commonly used status codes in ICD-9 that did not translate well into ICD-10 is the use of status or Z codes in therapy-only cases. Back in ICD-9, we had specific status codes for when the patient was not receiving skilled nursing care, they were only receiving physical therapy or occupational therapy or speech therapy or a combination of those three services. There were V codes in ICD-9 that would show that. Now, if you're one of those coders who like to use the general equivalency mappings or GEMs, and you try to map the I-9 codes for therapy only into an I-10 code, you are going to likely be coding incorrectly, because the GEMs will lead you to an incorrect code, which is usually Z47.89, and counter for other orthopedic aftercare. Now, CMS has told us, and the CDC and the coding clinic has told us, that there is no therapy-only code in ICD-10, even though there's a GEM that leads you to a code. According to the official guidance for ICD-10-CM, when we have a therapy-only case, the guidance tells us that we are to code the condition that the therapy's treating. That's what they are looking for. So example would be if the patient's receiving therapy only for a patient who has Parkinson's disease, rather than use a status code for therapy only, such as the mistakenly used Z47.89, we are to just code the Parkinson's disease, which is coded G20. So again, remember to always use your code book rather than a title lookup like ICD-10 search online or your general equivalency mappings, because those are just early suggestions. They don't give you any official guidance or conventions or anything like that. So make sure you use your code book. All right, so we've gone over some of the Z codes in Chapter 21, as well as some status codes and how they're applied in home health. So let's now practice what we've learned. In scenario number 1, your patient's referred to home health nursing services for monthly Foley catheter changes due to neurogenic bladder related to multiple sclerosis. She has a history of urinary tract infection. Most common mistake I see in this particular scenario is that the agency might mistakenly put multiple sclerosis as a primary diagnosis. And you can certainly code multiple sclerosis primary if you're giving services related to mobility training or something in addition to the Foley catheter changes that are needed. In this case, the only reason we're there, though, is the neurogenic bladder and the Foley cath changes. So for that reason, your primary diagnosis should be R33.9, urinary retention, followed by G35, which is multiple sclerosis, and then you have a status code for Z87.440 for the personal history of urinary tract infections. If this patient has a physician-confirmed neurogenic bladder, your primary code would then be N31.9 followed by G35, and an additional code for the type of urinary incontinence would also be needed, and you'll find that guidance at N31. Practice scenario number 2, the patient had surgical removal of left lower lobe of lung due to lung cancer. Nursing is ordered to assess the incision and perform routine dressing changes. There are no documented complications from surgery. The patient is dependent on oxygen and is a fall risk. In this case, we don't have a complication, so we're actually coding Aftercare. There is an Aftercare code specifically for surgery for neoplasm, and that code is Z48.3. We would then code the actual neoplasm, and you'll find that guidance at the Z48 category, and the code following that would be C34.32, malignant neoplasm of lower lobe, left bronchus, or lung. You then have 4 status codes to show what else you're doing for the patient. One is Z48.01, encounter for change or removal of surgical wound dressing. Remember, in this case, this is not a complication code, it's aftercare, and therefore we do code the dressing changes. You also have a Z99.81, dependence on supplemental oxygen. Z91.81, history of falling, which is also the code for a risk of falls. And then you need to also code Z90.2, acquired absence of lung, and that includes part of the lung. You'll see that as part of the code title and the guidance. All right, practice number 3. Mrs. Gray is referred to home health for nursing to instruct the caregiver on PEG tube feedings and care, and for respiratory assessments. The patient had a stroke 6 months ago and has had 2 bouts of pneumonia. It was found that she's having oropharyngeal dysphagia and aspiration, which is causing the pneumonia. The patient has a BMI of 44. In this case, we're first coding the dysphagia. That's I69.391, and this code's really specific in that it's a combination code that tells both the symptom and the underlying problem. So we have the dysphagia following cerebral infarction. So we don't have to code the sequelae of the stroke as an additional code because it's already mentioned in this code here. R13.12 is the next code because at I69.391, you'll see guidance telling you to specify what stage of dysphagia. So R13.12 is specific for the oropharyngeal phase of dysphagia. We then use Z43.1 because we are actually providing gastrostomy care in this case. It's attention to and not status. Then we have a history of pneumonia, Z87.01, and then we also have a BMI code for 40 to 44.9 in an adult, which is Z68.41. Scenario number 4, Mr. Smith is referred to home health therapy for physical therapy gait training after a traumatic amputation of all his toes on his right foot, which happened while he was mowing the lawn barefoot. The patient's on prophylactic oral antibiotic therapy daily for 3 weeks. Nursing will perform dressing changes until no more drainage is noted. He has fallen twice since the injury. So it's really funny, when I was looking up this particular scenario, there's actually a code for the right great toe, and then there's a separate code for all the other toes. And the reason, when you think about that, it makes sense is because if you lose your great toe, it greatly affects your balance. Whereas if you just lost one of the other toes, it might not affect you as much. In this case, the poor guy lost all his toes, so we have to code both of those. So your first code will be S98.111D, complete traumatic amputation of right great toe, subsequent encounter, followed by S98.211D, which is the complete traumatic amputation of 2 or more right lesser toes. And again, that's a subsequent encounter as well. You will need to also, according to the guidance, use a code for the external cause, and that's something that's in the guidance for the S category. So you have W28.000D, contact with powered lawnmower. Remember, when you're using external cause codes, if you use a subsequent encounter on one, you have to use that same encounter type for all of the codes. That's why they all have D. Last, you have Z91.81, which is the history of fall, or falls in this case, and then Z79.2 is the long-term use of antibiotics. In closing, we hope that you've learned a little bit more about Z codes and status codes from Chapter 21. We hope that you'll join us for our last installment of our 12-part series. In Part 12, we're going to be talking about the updates and changes that are coming to the code set beginning October 1st, 2016. And we'll also review some coding clinic guidance as to clarification of the code set that happened in the first and second quarters of this year. So we certainly hope you'll join us for Part 12. We also thank you for trusting us with your education needs, and we hope to see you again soon.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.